the province-wide rounds for this academic year being July to July. And Morgan has done a unique fellowship after completing his nephrology here at UBC and did a year of palliative care. So it was an official first ever palliative care and followed from nephrology fellowship. And so he's reporting in on things learned and ideas had, and hopefully we'll go from there. So Morgan, welcome.
Thanks, everybody. And I think we may have some palliative care divisional members calling in, and if you're there, thank you for tuning in as well. So I'd like to just chat a little bit about the Australian experience that I had. So we're going to focus a little bit in on that, which was over about a 3-month duration. I have no disclosure. This fellowship was jointly funded by the BC Renal Agency and jointly administered by the divisions of nephrology and palliative care. So obviously anything I say about them, that's good. I was paid to do it. I'd like to go over a couple things today with respect to my experience down there. So a lot of it will be reporting on what I saw and what the model of care was down there, and then sort of doing a bit of a reflection on how that might come back to BC. And then hopefully this will lead to some sort of a discussion at the end with respect to where you think we can go in the future, because I think this is the whole point. So at its core, this fellowship was really geared and designed because our nephrology population has a growing need for palliative care services. That's no surprise to any of us who have been involved with them. And there is starting to be more and more of a need to start to integrate symptom management and advanced care discussions deliberately into nephrology training earlier on so that our trainees can come up and tackle these discussions. And obviously understanding the landscape of the services within the local region is paramount to providing good care. So renal supportive care, just to define it really quickly, is essentially palliative care in a renal setting. And there's been a significant paradigm shift in how we think about this. From palliative care, it used to be something where you would come in toward the end of treatment where you were no longer able to have any medical options and you're looking at palliation. But now, and this is Dr. Hawley's bow tie model, you see palliative care come in much earlier. Essentially, it should begin at diagnosis and throughout the disease management. It's really a perspective and specialty that is looking at improving the quality of life by early identification of symptoms, goals, values, and looking sort of globally at patient well-being. We're all familiar with these sort of different trajectories of sort of organ failure, this being somewhat similar to what we see in nephrology, and this more classically seen in oncology. So why New South Wales, or why Sydney? They initially piloted a renal supportive care clinic in 2005, and they had a fully established service in 2009. And so they've essentially culminated in a decade of experience of integrating palliative care into standard nephrology care. And they've obviously undergone multiple growing pains and iterative changes. So it was really an ideal location to be immersed in the medicine, the administration, and sort of the program development of such a model. And Sharon Barber said the surfing is better there. You may recognize the group from some of the publications they have put out in various settings. And I think one of the things to note is that it crosses a variety of themes. So it talks about trajectory or prognostication, symptom management, decision-making, nutritional symptom management, and even consent on dialysis. Before we really dive into it, I think it's important to really understand what nephrology at St. George Hospital looks like. So this is a primary nephrologist model. And within BC, we sort of have a different smattering of models. Some of the sites are primary nephrologists, some of them are hybrid, and some of them are more group. In this particular setting, each nephrologist follows their patients from the CKD diagnosis on to dialysis initiation, transplantation, conservative care, And in cases of in-hospital end of life, they also fall there as well. Now, obviously, the transplant site for New South Wales is not at this hospital, so the patients would leave, very similarly go to their transplant center, and then return home to follow with their nephrologist. They do have other associated clinics similar to us. They have a renal options clinic, a vascular access clinic, and a renal supportive care clinic that I was aware of and was privy to. What you don't see here is a kidney care clinic. And so that is not part of their model per se. The renal options clinic is exactly that. It is a place for patients to go to talk about renal options and may consist of one or more visits as needed. They also have a split public and private system. And so some of the nephrologists also have private renal patients seen at the very confusing St. George Private Hospital, which I started and ended up at on my first day, wrongly. And then they are essentially transitioned, I believe, don't quote me on this, but into the public system because that's where all the dialysis is provided. So if we look back at where the inception of this idea came from, Dr. Mark Brown was sort of the visionary behind all of this. And it was sort of back in 2005 when he was rounding on dialysis patients and starting to notice that really they weren't thriving, much like sort of our experience. And back then, he said back in the day, the only thing you could really do was to increase the amount of dialysis. And even then, their quality of life really wasn't improving. At the same time, he started to notice more elderly and frail patients who were showing up at kidney clinic. And he was looking at them saying, you haven't started dialysis and your functional baseline is so poor. What would happen if we started dialysis? And he was sort of stuck because at that time, he didn't know what else he could offer. There was no conservative pathway. There was no service at the time to take on these patients. Around the same era, there was a high symptom burden that was identified in the dialysis patients in a study out of St. George's, where they started to use more objective symptom management scoring. And so this this recognized an unmet need for symptom management in that dialysis group. And interestingly, he also noticed that the patients who did have palliative care services involved were always very happy with their palliative care appointments. And so he went about developing a sort of nurse-led initiative and program. I'll read this for those who may not be tuned in video. The dialysis nurses were bearing the burden of frail, elderly dialysis patients who probably should have never started on dialysis. And oh goodness, it's probably a little bit hard to read. So what happened was in 2005, they had an initial pilot of this renal supportive care concept with essentially a palliative care physician and a nurse. And this started primarily with Professor Brown's patients only, because he didn't have a lot of colleague buy-in at the time. But over that duration, he started to accrue data on both the survival and symptoms. And a little bit further along in 2009, he was able to lobby the Ministry of Health to obtain 3 years of funding for this clinic. He also embedded at this time, or just prior to this, the education from a training perspective. So all of the nephrology registrars go through the renal supportive clinic. It's mandatory. And as things went along, a few years later, they've established quite a good reputation. And in 2012, they had started to travel all over Australia, not yet really having gone internationally, but they were giving talks in the sort of hundreds at various places within Australia. And he did recognize the audience at that time was primarily dialysis nurses. These were the individuals who were really seeing the burden of disease and suffering. And more recently, just a few years ago, the state established a statewide supportive care program. So it's really building on the St. George model and using that as a hub and having these community sites, which are the spokes, that sort of report back and have their training developed out of the hub. And now they have quite a great international reputation. And even during my short 3-month visit there, we had 5 different visitors, 2 local and 3 international. And in addition to myself, work with them. I've always been a believer in education, having our trainees as part of the program. It's compulsory for our trainees to attend the clinic. And if you look at their growth over the last several years since 2009, this is based on their 2016 annual report. I don't have 17, or it's not available online. There has been a significant growth in the inpatient occasions of service, as well as home visits, phone consults, and dialysis consults. You'll notice that the outpatient occasions of service have remained relatively stable. I think part of this growth speaks to the fact that you're having more and more nephrologists buy in, and they're involving their patients now, where they're the primary nephrologists, and getting them to the renal supportive care team. And this is also Dr. Brown. Oh, at every step, all of those steps we've been through, there's been barriers. The biggest barrier of all is consultant nephrologists. Absolutely the biggest barrier. If we look at some of the patient outcomes, and I don't really want to delve too much into their data because I'm more interested in their system, they do have a significant increase in improvement in their total symptom score by the time of their third clinic visit. And these are the top 5 symptoms reported as severe to overwhelming in their patient population. It includes pain, lack of energy, poor mobility, itch, difficulty sleeping. I put this little thing that's sort of floating in the right side just to remind myself that they also started an annual renal memorial service since 2010. And this is for patients and families to sort of share in the memory of their family members and loved ones. So if we look at the team today, it has evolved quite a bit from when it was first started. It consists of 2 clinical nurse consultants, 1 full-time and 1 half-time, 1 dietitian, 1 social worker, a clinical manager who is essentially the be-all and end-all of data collection, analysis, jack of all trades, essentially, and 2 physicians, Dr. Brennan, who has been there since the beginning, and he's had a background in primary care, palliative medicine, and he was a lawyer in his past life. And then the newest addition, who is a dual-trained nephrology and palliative care specialist. And this team sort of functions to provide sort of multi-area input. Obviously, they do symptom-based management. They provide care, support for carers and patients with respect to diet, social work, and psychological. They do advanced care planning. And they act as a resource for additional centers of care. So the nurses are actively doing educational sessions at other hospitals. And there is a coordination of research efforts through this team. If you think about how the patients get to the renal supportive care clinic, there can be multiple different ways. So their primary nephrologist can decide that in a particular setting, dialysis, the harm of dialysis may significantly outweigh the risk, and they may make the decision for the patient to be not for dialysis, and that patient would be automatically referred on to the RSC team. Patients who end up going to the renal options clinic, who then decide not to do dialysis, they also get referred on to the renal supportive care team. Inpatient teams from other health services are also sources of referrals, although a little bit less, and the renal team can refer their own inpatients to the RSC. I think the most important thing here to note is that dialysis nurses can refer to the RSC as well, based on their... That's lovely. I've just lost the slides. Somebody's checking email. Are you calling them? Yeah. There we go. I can see this. I can see my desktop, but I think the webcast is down. I have no idea. That's weird.
I can be. Yep, so I'm in the room because the speaker is doing his presentation. Oh, yes, it showed up. Yep.
There we go.
Okay, thank you so much.
Okay, I think we're back. Thanks for your patience. And so I was saying that dialysis nurses can also refer the patients. The patients can self-refer, although there's an automatic check with the nephrologist to see if this is appropriate. And then there's an automatic sort of letter that is generated based on dialysis symptom severity scores if they have scores that are scoring in the severe range. Patients who do end up going to end of life at home are then referred on to the community palliative care team, as this team only has limited capabilities to do home visits and community follow-up. So what does a typical outpatient clinic visit look like? It's quite a bit different from anything I was used to. First of all, it doesn't look at numbers in any way. You don't look at labs. You don't look at blood pressure. You literally start with how are you doing, and then you look at their symptom scores, which when you look at how they're booked for 45 minutes, you would think this should not take 45 minutes. I could see 4 patients as a fellow. But really, there's a lot of rich information that comes out of it if you leave it open-ended like this. And there is a very big focus on symptom screening and ensuring that what they've put into this, the IPOS renal, which is analogous to our modified ESAS, is truly reflective of their symptom burden. And there's a good check-in with respect to home supports and other caregiver issues, and of course, advanced care planning. And typically, they do end up taking 30 to 45 minutes. The inpatient service works very similar to, for those of you familiar to the St. Paul's Hospital palliative care team consult service, it works very similar to this in that the patients followed by the renal supportive care team as an outpatient are manually checked for sort of every morning for an admission to hospital. They have EMR issues just like as we do. And then they are automatically reintegrated into their inpatient care. So the nurses will go up and check in on how these patients are doing and see what needs to be done medically, if anything. And the focus there is to really provide that bridge between those outpatient discussions and their current inpatient stay. They don't have Promise or Pharmanet, so the renal supportive care team oftentimes takes a charge of the medication reconciliation with respect to symptom-based management, especially if there's been recent titrations in gabapentin or hydromorphone. And they provide ongoing symptom management as well as discussions around goals of care. They also receive new consults, and this is primarily for symptom-based management usually. The most commonly seen symptoms in this clinic include pain, sleep, pruritus, restless legs, cramping, edema, dyspnea, anxiety, and taste changes. And This is just a little figure showing the flow of patients through the Renal Supportive Care Service. And I think the interesting thing here is that of the 303 patients not for dialysis on a conservative pathway, 4 of them switched to hemodialysis over the time frame of 2009 to 2018, which I think is very remarkable, but also speaks to the fact that they continue to have a home and are cared for by this sort of dedicated team. Before we go any further, I want to talk a little bit about the Renal Options Clinic, because the theme of renal supportive care has now sort of permeated a lot of what is done programmatically. So like I said before, if patients would clearly derive harm from renal replacement therapy, then they are referred to the RSC clinic and then not offered dialysis, and that is fairly simple. But for those who may derive a benefit, or where there's sort of this clinical equipoise where you're not entirely sure, then they're referred to the Renal Options Clinic, which is a nurse-led clinic, much like our KCC model. In that clinic, the patients are presented with the following modalities, including PD, home hemo, transplant, and then conservative care. They also do a symptom score via the IPOS Renal, and then a touch calc, which is the online co-end prognostication data is collected. This is sort of the pathway of patients who attend the pre-dialysis clinic. You can see here the patients not for dialysis here, and then the patients seen by the RSC is in a dotted line because there's an overlap between those who are not for dialysis and those who are referred for symptom support. Now, some of the interesting things that came out of this Renal Options Clinic was some of the information that they gave their patients. So this is actually a document that all patients get. You probably can't read it, so I'll sort of read it to you. And there's a portion of it that says, what happens if I don't have dialysis? And it says, every patient with kidney failure has the option not to have dialysis. Research increasingly shows that survival on dialysis may not be any longer than without dialysis for patients in the following 2 categories: age 75 or older and coronary heart disease, or over age 80 with or without heart disease. And research has also shown that dialysis may not increase the length of life for some patients, particularly if they fall into the following category: patients 75 or older who have two or more of the following: other health problems such as heart, lung, vascular disease, or strokes, dementia, frailty, poor functional state on a day-to-day basis, and poor nutrition. I found this really interesting because it sort of put it right out there that in very black and white form to our patients that perhaps dialysis may not derive, perhaps they wouldn't derive a benefit from dialysis, and it's sort of in writing. This by itself sort of didn't lead to anything, but it was sort of an information for patients who came to the clinic to anchor further discussions on. But what was more interesting was this additional data that they provided their patients. So there's a section of the same document that says, how long will I live if I do have dialysis? And this is a table derived from the ANZ data, which is the Australian New Zealand renal database, similar to our core data. And it talks about the age at the start of dialysis and then the chance of surviving 1, 2, and 5 years, which I found when I first saw it particularly shocking because I'd never seen this data given to patients like that. And when I think about it, I initially thought, oh my God, why would you do this? And then the counter argument was, why wouldn't you do this? They also provided sort of the median survival times on dialysis for different age groups. So again, this is something novel that I've not seen particularly done, and it was normalized in a way that this was just something that was in the rest of the document that talked about the different renal options. This is, I'm not going to read through this, but basically this is from a different document that talks about conservative management as well as the support that you receive at St. George. There's a real focus for all patients that they not be abandoned. I think this is paramount and core to this movement and having this service established. This is a quote from Dr. Brennan during a patient interaction that he had in the clinic. "We need to find something to help you, because at the moment, this is miserable. We must do better. It is our job to find that something." And I think that quote sort of sums up this clinician as a person. I've gotten to know him over the several months, but that is who he is. He doesn't abandon his patients, and it's very clear in how he presents himself. And sort of the philosophies that have come out through this entire process include shared decision-making. So there's always this struggle between looking at complete patient autonomy, where they get to choose everything under the sun that they want, versus paternalism, which is where we decide what is best for them. And ultimately, both are essentially a flawed approach. And the emerging concept is that of relational autonomy, which is essentially a tailored physician recommendation, or in our case, a nephrologist recommendation. And this is what more and more of the nephrologists are doing. The patients are showing up at the renal options clinic with a recommendation anchored in previous discussions with their nephrologist with respect to renal replacement therapy, and perhaps which would be more appropriate. With respect to dialysis decisions, I guess the big question here is, do they do trials of dialysis? And that was what I was interested in. In general, they don't advocate or really offer trials of dialysis. And fundamentally, Professor Brown thinks that it changes the philosophy when the discussion has to shift to withdrawal of therapy. And certainly dialysis is not offered if it is thought to be harmful or the patient is undialyzable. Now, that being said, they do have the population of patients that we also have that sort of are hard set on dialysis, where you can't make the conclusion that it is for sure going to be harmful. And so those patients get dialysis, and those patients stay on dialysis. There's a large sort of Greek population who all sort of do this. And then, of course, I mentioned the principle of anti-abandonment, where regardless of your dialysis decision or your care pathway, there will be a team in place to sort of follow you. So if we bring it back home and we take a quick look at the two different programs, and this really doesn't do it justice. I don't think I've done their program justice, but I certainly don't think I've done our program justice. But both programs do have an objective symptom assessment score. They happen to use the IPOS Renal, and we happen to use the modified ESAS. Theirs, interestingly, doesn't serially integrate back into their clinic. So they do the symptom assessment, it gets transcribed into their data manager's spreadsheet, and then at the next clinic visit, that is not necessarily available. Whereas for us, we typically have tracking through PROMIS, and so we can sort of see the symptom scores. They also have a struggle with where to put ACP information, similar to us. So they have literally a binder, which has all of the ACPs for the patients that they follow and copies of that. That is as high-tech as it gets. I don't know if we're much better, because we sort of have our ACP information all over the place, depending on hospital and health authority. Some of the private patients, their data isn't captured. We don't have private patients, so we don't have comparison. And they don't have PharmaNet, which I have a love-hate relationship with, but after going to these clinics and having to re-identify medications in bottles that are not labeled, I have more of a love relationship with PharmaNet. And similarly, they don't have PROMIS. When I talk about PROMIS and talk about what we have in BC, they sort of drool and are jealous at the establishment of this sort of global database for data. And in Canada, at least, we've relatively recently, sort of approved the MAID procedure, and that has not become a thing in Australia. So those themes do not come out in this clinic. Now, specifically, if you focus on the clinic itself, theirs is a dedicated multidisciplinary clinic, but they don't have pharmacist support. Now, this is a clinic specifically for their renal supportive care patients. Our clinics are multidisciplinary KCC clinics, so we see all of our patients, and I really look at our KCCs as a powerhouse for doing great work. I mean, we essentially capture everybody, or we try to. And we do have all the services available. But I'm just going to take a step back here and look a little bit closer at their model and perhaps why there are certain strengths about having a dedicated renal supportive care service only. So in this particular case, an elderly patient presents with poor sleep as his primary concern. But symptoms are very complex, and they're intertwined, and they compound on each other. And in this particular case, it turned out that the patient's sleep was because of nocturia. And this was because of increased fluid intake, secondary to excessive flavoring. And that was because of taste changes that he had experienced. And so with the intervention at that level, by adding lemonade ice chips, water spray for dry mouth, and then a limitation and focus on limiting the evening fluid intake, the sleep was fixed, essentially. But it's just one illustration of a symptom which is cascading amongst other causes. This is another patient, an 82-year-old gentleman who's CKD stage 4, presenting with left cranial nerve V1 postherpetic neuralgia. And it was I know that picture is not cranial nerve V1, it's not been that long. I know where the face is. And this is just to demonstrate that some symptoms take dedicated serial reassessment and titration. This gentleman had been to clinic multiple times and was finally stabilized with a final regime of tapentadol, gabapentin, and amitriptyline. He had gone so far as to try acupuncture and a previous buprenorphine patch, which was not helpful. But this takes an intensive approach to treating a symptom. Now, we can make the argument that perhaps postherpetic neuralgia is not our domain. Regardless of that, this is an example of a symptom that does take that sort of approach. And certainly having done outpatient palliative care, that is the strength of having a dedicated service there. And this is one of the renal patients who said, "I don't know what not having pain is. Nothing compared to this, even when I had cancer." That was that same patient. This is another patient, another case, an 85-year-old gentleman with ischemic nephropathy, with an eGFR of 6 and a history of ischemic heart disease, recent stents times 5, who had an eGFR of 8 about a month ago. And it actually took about 12 months, over 12 months of deliberation and ongoing goals of care discussions to decide on whether or not he would pursue dialysis. He went so far as to actually undergo the PD orientation before he decided that he would not go for dialysis. And this decision was based on the fact that he determined dialysis was time-consuming, and that he realized he had outlived his neighbor and had a full life. And so it just speaks to the fact that you do need a serial following of these patients in some way. Another renal patient on advanced care planning. We didn't start talking about it until Dr. Partha brought it up. And so they are really looking to us to tackle these themes. And you might think that this clinic would be more specific to dialysis patients or those on conservative care, but there were transplant patients who were seen, and they can have significant symptom burden as well. So this was a gentleman with IgA end-stage renal disease with a transplant in 2002 who presented with brand new, progressive, moderate to severe, painful peripheral neuropathy in the setting of no other causes of neuropathy. And this was worse with ambulation and eventually required a buprenorphine and pregabalin as well as topical ketamine cream treatment. It was subsequently discovered that this patient had developed a tumor-related bowel obstruction and then had T-cell PTLD, and that this was thought that perhaps this was a paraneoplastic peripheral neuropathy. So it does sort of go back into the medicine that is at the root of it all, despite the fact that you tend to focus on the symptoms. You're still delving into what the underlying cause is. This is a patient who was well known to the Renal Supportive Care Service. It was an 89-year-old gentleman who was not for dialysis. He was eGFR 4 with a history of CAD and a recent MI in January. He was followed by the team for back pain, pruritus, nausea, and myoclonic jerks. And we literally saw him in clinic, and he went home and had a fall over the weekend. He sustained a subdural hemorrhage with no midline shift, and a left hip fracture. Was, of course, admitted to the ICU because his ACP had not been recognized or followed. And there they were in the ICU with his poor wife worrying, and the medical team puttering and talking about fixing this hip in this gentleman who previously didn't want any of this. And so the Renal Supportive Care team sort of stepped in and advocated on behalf of the wife, who felt a little overwhelmed by all these other experts who are weighing in and saying, we should go and fix this hip, so it's going to make it feel better. And eventually his wishes were respected, and he was stabilized and transferred to hospice. This is from another patient that we saw in clinic around her fears. She said, when my kidney function dropped from 12 to 10, I thought, this is it. I thought I was dying. And this is another interesting intervention that came out of this team in New South Wales, that multiple patients were presenting with taste changes. Now, this wasn't part of the IPOS renal, but they had added it on so that they could monitor whether or not this was becoming an issue. And it allowed for their dietitian to sort of develop a protocol and recommendations around certain types of taste and what you might do for it. And this is an example. This is on their website, but this is an example of what they recommended. They are now piloting a sodium bicarb wash to see if this improves taste changes as a dietary quality of life intervention. Their social worker has also undertaken, I believe, several legacy projects related to dignity therapy, which again is a perspective that looks at restoring the patient's meaningfulness to their life or how they perceive it. And so far, this clinic had been manned by a palliative care specialist and clinical nurse consultants, with the recent addition of a dual-trained palliative care nephrologist. And so the question is, why would we embed nephrology? And it can be as simple as, we understand renal replacement therapy the most. The decision to undergo this therapy is complicated, it's multifactorial. There was an elderly patient who was adamant that he wanted to start renal replacement therapy despite recommendations that it might actually prove to be more harmful than benefit. And when you dug into it, his primary reason for wanting life-prolonging therapy was so that he could take care of his demented brother. But really, after understanding that if he started in-center hemodialysis, that would not allow him to do this, then he sort of understood that dialysis would not help him accomplish his goals. And in fact, he may actually do better taking care of his brother in the limited time he had left and coming up with a plan for when he was not there. And I would argue, we go back and forth on this. I think all of us have a different stance with respect to ACP discussions and whose role it is. Some people think it should be primary care. Some people think it should be the specialists most involved in their care, if it's heart failure or cancer. But I would argue that discussions around and indications to stop renal replacement therapy are particularly our domain and expertise. And that if we have somebody in life-prolonging therapy, that we do sort of have an ownership over part of these discussions. And I think next is a couple letters, and this is something else that was novel that I had not seen previously, which was essentially a dictation. You might not be able to read that, so I'll read it to you, around some soft indications where you would discontinue dialysis. So the first letter says, I've today discussed with blank condition with his, I believe, wife and daughter. In summary, he has metastatic colorectal cancer with metastases to multiple lymph nodes and peritoneum, but no clear solid organ metastases to date. Right heart failure with severe tricuspid regurgitation and hepatic congestion, and a background of listeria, endoluminal graft infection, and hemodialysis dependency for roughly 10 years. We discussed the following today. Number one, in the event of having a stroke that left him with incapacity, he would wish to withdraw from dialysis and be managed with supportive care. In the event of cardiac arrest, we would not proceed with immediate resuscitation attempts due to the low likelihood of survival with quality of life. In the event of a illness serious enough to necessitate intubation and ventilation, we would not proceed with that level of treatment, and at such stage would withdraw dialysis and ensure good supportive care. In the event of a serious infection where the treating clinician felt there was a good chance of response to treatment, then we should proceed with this, with these therapies, such as intravenous antibiotics and short-term inotropes to raise blood pressure, to be continued along with dialysis whilst ever the treating clinicians felt there was a good hope of recovery from that illness. This is a fairly short letter, but I found something like this to be useful in framing these patients and sort of how far we go. Because oftentimes the question is, when do we stop dialysis? And our colleagues like to scoff at us in Emerge, or at least at the fellows, and say, well, you just keep dialyzing these people. And you go, it's not that simple, but on some level you are right in that sometimes I don't know the end point either. I'm not going to read the second letter. It's very similar, but it does speak to the indications of discontinuing dialysis. Their ACP form is very, very simple. It's sort of a template used to frame the discussion where they go through the different levels of intervention similar to how we would do it, as well as determine who the substitute decision maker is, if there is one. This is not groundbreaking in any way. And if you look at their statistics at the total completed ACP, amongst their not-for-dialysis patients, they have about a 74% completion rate. And of their dialysis patients who met criteria, and they're using this surprise question as criteria, 42% of them had done it. So definitely a focus for them and a work in progress. Their goal is obviously 100%. And this was just a sample of their most recent consent for dialysis after they published that consent may or may not be done entirely properly. They included this form, and on the form is that the patient should know, or the doctor should have explained, that the option and role of conservative care as an alternative dialysis. And this just completes a sort of informed consent package. So I think what you see here is sort of just a quick snapshot. Again, I'm not really doing it justice. I wish, I could go into more, but of this theme that is starting to permeate all areas of their renal care. And I think that over the last 10 years, they've done some really good work, and certainly some of the things that they do are very novel in terms of when I compare it to the training that I've undergone here. And I often wonder whether or not normalizing some of these discussions even more would be feasible with our patients. And then I'm just ending with this quick recognition of Dr. Brown, who was recently honored and inducted, sort of appointed as a member of the Order of Australia, which means now I've worked with 2 orders of individuals. And this is his sort of mantra that I really like. And essentially, it's finding the right treatment for the right patient at the right time of their life. Special thanks really to the New South Wales Renal Department, Dr. Levin, Dr. Hargrove, Dr. Chen, locally. All of this would have been sort of impossible without your mentorship and support. And thanks obviously for coming and listening to this very short snapshot of my experience.
On one of your slides, you put in the renal support team, and in blue you wrote lack of pharmacist support. Now, I think, speaking for myself, that's certainly the aspect of care that is the most challenging for a nephrologist, is sort of medication management with sort of novel therapies. So how do they do they rely simply on the physician to have extreme expertise in medications?
That's an excellent question. So what ends up happening is, for the symptom-based management, yes, it's completely physician-led. The medications that are used routinely, just sort of, Dr. Brennan's just done it so long that he knows That being said, when there are checks that are required, the patient returns to their sort of home territory. So there is a pharmacist assigned to, for example, hemodialysis and peritoneal dialysis, and there is a pharmacist available for clinic. And unlike our KCC, where all the resources are there at the same time, you could individually consult, for example, social work if you needed them, if the patient wasn't tied to one previously. So that's how they would do it. But the physicians, they handle all of the symptom-based management, which I think also speaks to the fact that it takes time to accrue the knowledge of the medications and how they're used.
So thanks, and I think it's really great to get different perspectives. If you don't have a KCC model, then you have a renal support care model. If you have individual, so I think it's just interesting to see how different systems solve a problem of integrated care a different way. And I think the learnings are great, and I think there's some things that we do that are similar to this, but we've not articulated them or pulled them out, or maybe the fellows aren't exposed to them. And I think that was the other thing that I got from your talk, is things that perhaps you don't know that are done on a regular basis, may be part of our inability to share some of that. But I think it's great, and one of the goals of this, I think, was to say, what are the pieces or the tools that you saw there that we might be able to integrate or critically look at as being helpful. And the one that you and I talked about the other day, but is interesting, is I don't know how many of us actually say to the patient, your probability of surviving is X percent. What I do know from some of the patient work is they don't understand what X percent means. Like 72%, I'll take the 18. Like, that's not really what I was giving you, if you know what I mean. Like, so it's kind of an interesting thing. And so how do you best communicate that? Because while it looks really nice on the piece of paper, how many of our patients would understand 78% probability of survival for 2 years? So I don't know if other people have some thoughts about that, but maybe working on some tools that translate that and overtly showing it may or may not be a benefit. So interested in other people's thoughts, as well as yours, obviously.
I'm not sure if you can hear me. So, yeah. So actually it was trained in Georgia as well. So the system there is actually, even though we don't have a pharmacist, the medication reconciliations are done by the nephrologist. And then, as Morgan said, the palliative care, the renal care only focus on symptoms. So even if you present to a nephrology clinic, if you have symptoms, pain management, other issues, the nephrologist wouldn't adjust the medication. It's actually then you will refer back to, because the nurse is actually always on site. You can always call them saying, I have this patient, we have this problem, do you mind adjust that? So they do have the record of what they're adjusting for medication, hydromorphone, gabapentin. Because one of the things is that quite a few medication they use are actually off-label use. So especially gabapentin, we use it a lot for itchiness, for restless leg, and for neuropathic pain. It's actually a very, very small dose, can down to like 50 milligram or even less than that. So that's why Dr. Brennan and his team sort of dominating on managing that side of the pain and the symptom control rather than the nephrologist. And as one question for Morgan is that one thing I found, so as you said, Prof. Brown said the same thing, as it's much easier to not start in dialysis, but much harder to withdraw. And that's why they have very clear guidelines saying age of 75, 1 out of 4. But that's really focused on hemodialysis, because interdialytic delirium, confusion, other things. One thing I found here in BC, we do palliative PD. I'm just wondering what your perspective, being to both sides, what your thoughts on palliative PD. Because I talked to Mark, he just said absolutely not. It's just not for dialysis. So I'm just wondering what your opinions are.
Yeah, so the way I think about this is really goes back to what are we trying to do, and is it feasible? So if the goal is for the patient to sit at home with their cat, or actually probably not a cat with PD, but if the goal is for the patient to remain at home or minimally functioning from our perspective, but yet still enjoying their particular quality of life, and we can achieve that with our therapy, then I'd say go ahead. Because I anchor back down on what the principle is here. And for every patient, unfortunately, there's no gold standard in what quality of life means. Everybody has their individual thing. And in fact, it's much more useful to me to have had that discussion with even a patient who says, my quality of life is really to have everything done until it's absolutely futile, and then to go more. That, to me, is actually still useful, despite it being, quote-unquote, unreasonable, because now I understand what that means, if it can be articulated like that. And so I think there is a role. I think there is absolutely a role for palliative dialysis. And it can come in different forms. It can come in hemodialysis and it can come in peritoneal dialysis. But it really depends on what the goal is that you're trying to accomplish. And I think there's a lot of tinkering and there's probably a lot more work that can be done in this area with respect to patients who are sort of on that cusp where their goal is not necessarily life prolongation so much as good symptom control, and dialysis would help them accomplish that.
Since we started to normalize the whole notion of conservative care pathway and a pathway through KCC due to the work that has been done in all the KCCs, we've had an increased uptake in conservative management with good palliation, with very little last-minute switch back into dialysis. And I think, again, it speaks to the integrated care. And I think that's the hard work of the KCC model and the nurses and the extra training that they've been getting in terms of modality change. So I guess there's different ways to get to the same place.
Oh, absolutely.
I think that's one of the beauties of seeing different systems. There isn't one way. And when you have a mixed system, as in Australia with the private and the public and the various HSSs and all that stuff, you create this model. And when you have a different integrated system, you create our model, perhaps.
Mm-hmm. Yeah, absolutely. I think our KCCs have done a phenomenal job in keeping our patients on the pathways that they've selected and keeping them well. I think there was a question at St. Paul's.
Yeah, I think a big part of this is just all about individualizing therapy, isn't it? It's exactly like the mantra that you presented on that last slide, the right therapy for the right patient at the right time. So I know that this whole thing about providing palliative dialysis for patients with a limited life expectancy, which, let's face it, is all of our patients, I would say that there's a lot of nephrologists who would not say, no, absolutely not. In fact, I'd say most wouldn't. And it's up to the individual patient. So even if the patient has a 6-month life expectancy, if that life expectancy, that time is good time for them, an important time, then I don't think it's inappropriate. And I think most nephrologists in Australia, in fact, would offer dialysis for a patient in that situation. For example, a patient that I've seen earlier in my training was a 32-year-old with metastatic melanoma, not expected to survive more than 6 months to 1 year, but he was mobile, living on his own. He was working on his laptop while he was in hospital. And this is a patient who ended up needing dialysis, and we chose to offer it. And with him understanding that his life expectancy would still be, not different because of his other unrelated life-limiting illness, but that time would be good time for him. So I don't know that this sort of blanket 6-month survival would not offer dialysis is necessarily true in all situations. And I think going back to that mantra, it's probably not the case.
I agree.
Morgan, hi, it's Bev.
Hi.
Can you tell me, because I always have difficulty kind of at the back end where, the patient isn't doing well, you don't think they should continue with dialysis, but it's always the family or the patient saying, no, they want to continue, even though their quality of life is very poor. So, in Australia, did you have the opportunity to see what their approach is? And is it a similar problem there, or are they more successful with convincing patients to withdraw from dialysis?
I think so. The problem is not unique. They have the same challenges there as we have here with respect to the families swooping in essentially and saying that they want therapy to continue where patients may or may not want it. I think what may be done a little bit better is they've had enough time now for a lot of their patients to have front-loaded these conversations so that they can sort of anchor back on the discussion when the patients were well and use that in the discussions with the family. That being said, you're still fairly stuck, because the patient's families can, in some ways, overrule you if they're the substitute decision maker and the patients aren't there to speak for themselves. And so we run into a very same struggle that we have here. And it's just sort of very carefully navigating the discussion as you would with any patient or family. I don't have the magic bullet, Bev. It just comes down to having that sit down talk with them.